Okay, good evening, everyone. As I have already been presented, I will start with a really brief background. T helper 17 and T regulatory cells play a key role in HIV infection and mucosal defenses. A reduction of T helper 17 cells in female genital mucosa of HIV-positive women has already previously been described. However, the effects of antiretroviral treatment, or ART, in these T cell subsets hasn't been studied in depth yet. We included 3 groups of study. First, a group of women seronegative for HIV infection, a second group of HIV-infected women that were naive of antiretroviral treatment, and a third group of HIV-infected women under antiretroviral treatment with undetectable viral loads. From the 3 groups, we obtained cervical mononuclear cells, or CMCs, and also ectocervical swabs. The cytokines secreted by CMCs after stimulation and the chemokines in ectocervical swabs were quantified by cytometric breath array. We quantified IL-17A, 17F, 21, and 22 as T817-related cytokines, and IL-10 and TGF-beta1 as Treg-related cytokines. We found that HIV-positive group without treatment show diminished proportions for almost all T helper 17 cytokines. We can see the differences for IL-17A, 17F, and 21. Of note, we also found diminished proportions of positive responses in the under treatment group for IL-17A and 17F. When Treg-related cytokines were analyzed, we only found reduction of positive responses for IL-10 in both HIV-positive groups. We then analyzed the global patterns of secretion of T817 and Treg-related cytokines. We found for T817-related cytokines that HIV without treatment group show severely modified patterns of secretion. We can see the differences here and here. While the under treatment group tend to restore these patterns. However, even in the under treatment group, we found diminished percentages of the portions of samples secreting 4 cytokines and higher levels of samples secreting with no cytokine production. When Treg-related patterns were analyzed, non-significant differences were found. We also analyzed 13 different chemokines in ectocervical swabs. We found differences for both HIV-positive groups with respect to the HIV-negative one for 3 chemokines. Lower levels of CXCL5 and CXCL1, both chemokines that are mostly associated with neutrophil recruitment and that have been described to be induced by IL-17. And we also found higher levels of CCL17, which is a chemokine that is mostly associated with the homing of Treg cells. To inquire if the CM6 function deterioration observed for T817-related cytokines could be related with the lower levels of chemokines detected, we decided to divide the HIV-positive group under treatment in 2 according to the number of T helper 17-related cytokines secreted by the CMCs. The 2 groups were at least 3 or 1 or less. Interestingly, we found lower levels of CXCL5 and CXCL1 in the 1 or less group compared to both the HIV-negative one and the at least 3 one. We also found in the HIV under treatment group positive correlations between IL-17A and CXCL5 or CXCL1. To conclude, we think that these results suggest that HIV infection severely affects the functionality of cervical mucosal cells, mainly in relation to T helper 17-related cytokines. Also, antiretroviral treatment could not totally restore T helper 17-related immune functions at the female mucosal level. HIV-positive under treatment women with lower quantities of T helper 17-related cytokines had decreased levels of CXCL5 and CXCL1 chemokines, And we think that it should be evaluated if earlier start could prevent this HIV infection effect to occur. I would like to thank the organizers to let us present this work. I would like to thank my director, Maria Magdalena Gerardi, and also the Instituto of Investigaciones Biomédicas en Retrovirus y SIDA, where this work was made. And I would especially like to thank all the patients who agreed to participate in this study. Thank you very much.
So we'll take some questions now, and we'll also take questions at the end if anyone has a question. Peter? Do you want to stand up there?
Very nice presentation. Peter Hunt from UCSF.
Thank you.
A few other groups had suggested that in individuals who start ART at very early stages of the infection, that there can be some relative preservation of Th17 cells. Do you have a sense of how early or late the women in this study started ART during chronic infection, very early?
Yes, all the women in this study started ART in the chronic stage of infection, like with lower levels of CD4 counts and everything. That's why we think that earlier start may prevent this effect to occur. However, it has been described not specifically in genital mucosa, but yes, in gut and intestinal mucosa, that T helper 17 depletion occurs very early after the infection. So I don't know what would be the real effect, but we think that it could be better. The earlier start could help prevent this depletion.
Great, thank you.
Thank you very much.
Yeah, just one other question. So I noticed there were two groups of individuals, with the HIV ART group with really a peak group on the top and a second group on the bottom. Do you know what could be different, maybe CD4 counts between the two?
No, we checked that, but we didn't find any differences, just variation between people.
Okay, so we'll go to the next speaker. This will be Dr. Jean-Pierre Routy from the Chronic Viral Illnesses Services at McGill University Health Center. He's going to talk about the effects of ART on reducing fungal translocation in HIV-infected patients.
So thank you very much. Very pleased to be here, and congratulations to be here during your lunchtime. So we will try to do a continuity from the previous talk to see the effect of antiretroviral treatment for marker of indirect gut damage, the fungal translocation. So this work was done by the team of Montreal from University of McGill and University of Montreal, including all the clinicians who recruit patients in the study, and key postdoc and students, like on the slide, who perform the lab analysis. And that's the fruit of two cohorts, the primary HIV infection cohort and the aging. So if you are in this room, you know that HIV is very toxic for the gut CD4 T cells, and as a consequence, lipopolysaccharide and soluble CD14 have been validated as a marker or associated of bacterial translocation. There is the beta-delta glucan, is a major component of most fungal cell walls and can be released during either colonization phase, so with a fungal growth without causing too much damage, and also during tissue invasion process. Beta-D-glucan represents a soluble presumptive diagnostic for invasive fungal infection, and it can be used as a clinical test in many hospitals and may predict or increase the probability to diagnose pneumocystis infection or aspergillosis. Indirectly, outside invasive infection, beta-D-glucan is being considered as a marker also of inflammation linked to neurocognition dysfunction, fungal translocation marker, and more recently presented in part at CROI predictor of non-AIDS event and maybe superior to many classical validated prognostic factors. However, the contribution of ART in improving or correcting the increase of beta-D-glucan as a fungal translocation in people not being sick from invasive infection remain unknown, and we will try to see what's happened during the early phase of infection in chronic, in those being treated and those not being treated. So the population was 160 HIV-infected patients, not having any opportunistic infection, cancer or colitis at the time of study participation, and from two cohorts, the Montreal acute infection and the Canadian aging one. At the first glance, you can see that there is an indirect relationship with CD4. More you have CD4, better you close to the normal low value of beta-D-glucan in your plasma. If you have below 200 cells, you may have much more beta-D-glucan in favor of damage of gut barrier, as reported by so many people, and those including in this room. Viral load, for those untreated, there is also a strong relationship, and as a marker of epithelial gut damage, if you have more damage, you may expect to have more fungal translocation, as it is so well known with lipopolysaccharide and bacterial translocation. So we find similar damage, more epithelial gut damage, more circulating beta-D-glucan. Correlation with other key markers. So first of all, the brother, in a way, the bacterial translocation, the twin brothers, the lipopolysaccharide, so the image for the bacteria, also a very strong correlation, and the same as one of the ligands of LPS, the soluble CD14, linked to beta-D-glucan plasma level. On systemic activation, of course, IL-6, that is correlate with any bad things, including normal aging and nearly all disease. More interesting, the interleukin-8, which is a cytokine who will attract a neutrophil to the site. You can see a very perfect or correlation in favor of the biological linkage to dectin-1, its receptor, that when ligate to the receptor, increase the IL-8 secretion, so in favor of an active role maybe of this compound circulating too much in the plasma. Effect of ART now in different groups and compared to lipopolysaccharide. So you can see in brown, in a very early patient not being treated, they're still higher than in blue, the uninfected control. And you can see for a subset that were treated, the level decrease. And you can see for the one, in fact, the opposite way, but the ART treated in primo, the small square on the top, there is no change, so no improvement, but no worsening. And on this part of the screen, when you have no ART in acute infection and you follow the patient 2 years, you can see that there is a kind of universal increase of the beta-D-glucan in favor of early mucosa damage, and maybe for genital mucosa can be the same, but the digestive mucosa seems also to be damaged, and very early ART just stop the damage, don't revert to normal. When you go to chronic ART untreated, the level is more elevated, is statistically different. Relatively sad, the chronic ART patient who were treated for 12 years without blips, with therapeutical success, no difference versus the untreated ART in favor that what can be damaged, at least from the gut translocation for the fungus marker didn't change much. It changed partially for the lipopolysaccharides. The long-term 12 years treatment lead to some decrease of LPS without go back to uninfected status. So to keep in the 5 minutes time and to be in the nice city of Amsterdam, so as a conclusion, beta-D-glucan plasma level is elevated in early, it can be as early as 4 weeks, and in chronic HIV infection. It represents a new plasma marker of systemic immune activation. For early heart intervention, definitively prevent level to further increase, but without normalization. In fact, there is a plateau. And in chronic infection, there is also no change level even after 12 years of success when treated. As the future direction, I think the question will be to, is this marker, whether or not will be just another marker that Peter Hunt can put on his list, or it can be an independent player in HIV pathogenesis, and if it is the case, a specific intervention can be designed, as you know, some people are born being healthy, candida, and can be a trigger for some immune change. Thank you very much.
The floor is open for questions. I'll start. So do you see any association with CD4-CD8 ratio in the virally suppressed group with
Yes, there is a ratio. Of course, is less than the CD4. So so there is a link with the ratio.
Great. Peter?
So a very nice talk. So in your comparison of the chronic untreated individuals with the treated patients who you said had been suppressed for about 12 years, they're different individuals, right? So is it do the ART suppressed individuals have lower nadir CD4 counts than the untreated individuals, and might that account for some?
Yeah, it may account for a part, because the chronic treated are around 700 CD4 T cells, and the chronic untreated are around 350, and there is a slight difference in the nadir. But still, I think the recovery of T cell didn't change much, mainly for these two markers, and we also present in previous data improvement of general immune activation, but LPS at that time were not fully improved despite important immune activation decrease when treated within 3 months of infection. So there is still a damage, and I was very pleased by the first talk showing that damage may persist even in any mucosa after significant treatment.
Yeah.
So you also mentioned this was a combination of 2 cohorts, primary and an aging cohort. Do you see any relationship with age, with the levels of?
No, we did a multivariate analysis, and age, sex, origin from cohort was not linked, was not biased in the data analysis.
If there are no more questions, we'll go to the next speaker. Okay. So who's the next speaker? So the next speaker will be Shalene Naidu from Stellenbosch University. She's going to talk about the persistence of myeloid cell-associated inflammation in HIV-infected children after 8 years on early initiated therapy, the key role players in HIV persistence.
Good afternoon, and thank you for the introduction. I am indeed all fired up, as the session states, to present some data relating to the immune status of South Africa, children infected with HIV in South Africa. So just for some brief background, we know that the pathogenesis in children is seemingly different compared to adults. Children have longer viral set points, they have faster disease progression, and there's rapid CD4 cell turnover. Now, ART has been revolutionary in significantly lowering the morbidities and mortalities of depicted by HIV disease in both adults and children. And in 2004, the hallmark of a randomized controlled SURE, as most of you would be familiar with, the trial paved the way forward for changing WHO guidelines in favor of early treatment in HIV-infected children, thereby showing improved clinical and immunological outcomes. However, even with long-term suppressive therapy leading to undetectable viral loads, decreased reservoir sizes, reconstituted CD4 counts, the immune system remains in a state of dysregulation and depicts a state of chronic inflammation, which can be defined as the prolonged duration of inflammation with active tissue injury and healing proceed simultaneously. Now, chronic inflammation has much implication in the onset of disease related to the cardiovascular system, metabolic diseases, and neurodegenerative diseases. Yet there remains a gap in the knowledge of immunological outcomes and subsequent morbidities in HIV-infected children in South Africa. So the aim of this study was really to characterize the immunological outcomes in HIV-infected children following 8 years of suppressive combination antiretroviral therapy in South Africa. So this was a cross-sectional study design that was implemented as part of a follow-up of the well-known SURE cohort, the children with HIV early antiretroviral therapy, and this is after 8 years of suppressive therapy. Now, we also recruited age and demographically matched controls consisting of HIV-exposed uninfected as well as HIV-unexposed uninfected children. And through the use of basic immunological assays, inclusive of Luminex, multiplex, ELISA, and multiparameter flow cytometry, we aim to measure a number of immunological parameters that could provide us with information on the immune functioning of these children. So we aim to measure multiple soluble T-cell and monocyte cytokine and chemokine-related biomarkers, including biomarkers of gut translocation. We then looked at a T-cell subset of distribution, activation, and exhaustion. We evaluated monocyte subset distribution and activation. And then as part of a subset analysis, we also measured HIV cell infectivity by use of an integrase cell-associated DNA assay. Now, just to provide an overview of the clinical parameters of the cohort, we have a total of 160 infants enrolled for this particular study. 88 of them are HIV infected, 32 exposed, and 41 unexposed, uninfected. Now, the time to ART initiation within our HIV infected group was 2.1 months. They had a median baseline CD4 count of about 1,700 and a median baseline CD4 percentage of about 32%. Now, if we look at the median cell-associated DNA, we could see that from a baseline of 1,500, there was a significant drop in cell infectivity to a CAD value of 32.5. So there was no particular difference related to the CD4 absolute or CD4 percentage count at 8 years on suppressive therapy between all three of the groups. However, there was a significant difference in the absolute CD8 and CD8 percentage counts within the all three groups. And there's a significant difference between the CD4-CD8 ratio. Now, just to provide a snapshot of the 40 biomarkers that we evaluated within this cohort, you could tell by looking at the three groups that there's differences between the HIV infected and that the controls, exposed and unexposed, look relatively similar. So Z-scores were allocated to generate this heat map with the blue showing more on the elevated side. So the first key finding within our analyses was that there was a significant elevation in the biomarkers that were associated with chronic inflammation and monocyte and dendritic cell activation. And we see this by significant elevated levels of vascular endothelial growth factor, the platelet-derived growth factor, and the more commonly C-reactive protein, TNF-beta is elevated. Monocyte proteins are upregulated, IL-1 and interferon alpha. However, if we look at the other biomarkers that we evaluated, we see a decrease or a decrease in the IL-1 beta, TNF alpha, and the IL-6. And this is particularly interesting considering the elevation of the IL-1 alpha. And we presume that this decrease in M1 cytokine expression may be depiction of an M1, M2 macrophage switch that is happening, which is more indicative of a chronic inflammatory state related to the monocyte macrophage lineage. We also did additional analysis evaluating the monocyte distribution using multicolor flow cytometry. And when we looked at the classical, intermediate, and non-classical populations of monocyte, we saw that there was an expansion of the classical subset within this group of children. Now, this is seemingly different compared to untreated adults, where there seems to be a higher non-classical CD16 high subset that are expressed in relation to the controls. So the state of information that happens in the monocyte can clearly state that there might be some kind of inflammation happening within the innate compartment of these children. Now, when we looked at the biomarkers of gut damage, we see a clear elevation significantly within the HIV-infected children after 8 years on therapy, with high levels of LBP, soluble CD14, soluble CD163, IL-18, and IL-17F. All these biomarkers have been documented in the literature to have some association with gut damage. And if we look at a correlation between these markers, we see that there's a clustering in the PC plot on the top right, where you see a clustering of the key markers related to each other, which then show through Spearman correlation that there's a positive and significant correlation between these markers. In addition to this, if we look at the clinical parameters, we see that baseline CD4, absolute CD4 counts at 8 years, and absolute CD8 count at 8 years have some sort of relation to the expression of these gut markers. So these clinical parameters could be predictive of the gut damage that may be happening in these children, contributing to chronic inflammation. Now, when looking at the biomarkers that depict T-cell mediated responses, we see significantly lower levels of IL-3, RANTES, GCSF, interferon gamma, TGF-beta, and IL-1. Now, we wondered whether this was in fact due to a degree of immune exhaustion that exists in these kids. And so we evaluated a host of immune classical markers of exhaustion, inclusive of LAG3, PD-1, TGIT, and TIM3. And what we found was that there were significant differences, as you can see in this box and whisker plots, that there's an increase in all of the exhaustion markers that we had measured within the HIV-infected children. This was significant for LAG3 and TGIT. So we also measured immune activation depicted by CD38, HLA-DR, Ki67, and 69. And for each of these, we actually found decreased levels of immune activation. Now, this, coupled with normalization of the CD4 count in these children, may suggest a long-term therapy restores the lymphocyte compartment to apparent normality, but a degree of immune dysregulation still exists, depicted by immune exhaustion. So to conclude the main findings of this study, we found that children infected with HIV at birth show immune dysregulation despite early therapy, reconstituted CD4 counts, low cell-associated infectivity, and long-term viral suppression at the age of 8 years when compared to their age-matched controls. There is a particular increase in the biomarkers that are associated with chronic inflammation, and there's an increase in the plasma bio and cellular markers associated with monocyte activation. The monocyte and macrophages may significantly contribute to this immune dysregulation, shown by the M1, M2 macrophage switch, also by the interplay between IL-1 alpha and IL-1 beta. And this serves as a key hallmark for chronic inflammation. There's also evidence of gut damage at 8 years on suppressive therapy, as seen by the elevation of markers of gut damage and their correlation with each other. The clinical parameters that may be predictive of this gut damage include absolute CD4 count and CD4 NADA. And then we also show a decrease in cytokine markers associated with T-cell activation and function, and this degree of exhaustion exists within the acquired cellular immune compartment. In terms of the relevance, we asked the question whether chronic inflammation and immune dysregulation holds a number of clinical concerns within HIV-infected children. Within our cohort, there's ongoing studies looking at cardiovascular outcomes, where data was presented at CROI in 2017 that showed a correlation between biomarkers of SV-CAM and MCP1 with vascular stiffness in these children. This prompts further questions related to the gut-brain axis and what the implications of chronic inflammation in these children may hold for these outcomes. Thank you.
We'll take the next open for questions.
Hey, thank you so much for your presentation. And I'm an epidemiologist, and I sit here trying to get some insight into mechanisms because I study some of the same kids that you have, which are HIV exposed, unexposed, and community-controlled children. Yeah. And so the question I had for you, and your last slide got at one aspect of which, what does this all mean for functional outcomes? So you're going to be looking at the gut-brain axis, which is excellent. So maybe next year we'll know about cognitive function, if it's related to that. I am seeing something in my data I wonder if you're seeing in your setting. So in our HIV-exposed and infected and so we look at anemia over time in these children. And what we've tended to see, at least our data is suggesting that there might be a change in the, you have this change in the kind of anemia. So when we type the anemia, we see, we're tending to see an elaboration of anemia of nutritional sources in HIV-infected children and different, just a strike different pattern that is a little bit complicated thinking about anemia over time, the various patterns we see. But I wonder if you think, or if you have the opportunity to look at anemia, potentially change in the etiology of anemia and how that might be related to the immune parameters that you showed.
We have access to the data. I haven't particularly looked at it in relation to immunological parameters, but that could potentially be explored further. But no, I haven't looked at the anemia patterns in these children as yet.
Okay, at the back.
David Miller with Panaware, United States.
Hi.
Some of the same definitive pro-inflammatory biomarkers that you looked at in this study are also implicated, obviously, in HIV-CVD and was shown in the REPRIEVE study. And cardiovascular disease is becoming much more prominent in the patient population. We've been hearing a lot about the gut-brain axis connection. Yeah. Is there a way to establish the gut-heart axis from the data that you put here, and could that elucidation be done quickly because there's a definitive need to start addressing some of these GI complications?
Yeah. So Professor Steve Innes, he's particularly assigned to looking at the cardiovascular disease outcomes. And there's Dr. Barbara Lawton, who's sitting in the audience, and she's been documenting neurocognitive outcomes in these kids. So there's a lot of clinical data that is emerging within this cohort, and it's for us to basically bring it all together and understand what relates to what. So as part of future studies, we hoped to look at immunological parameters, cardiovascular, and to look at the neurocognitive outcomes, and then to actually draw inference on what this actually means clinically for these children.
Just to follow up, how large will that study cohort analysis be, predictably? That seems huge.
Yeah, so it is quite huge. So this is just kids from the Cape Town SHRE cohort, of which we have 88 HIV infected, and we matched them with demographically matched controls. And then we also recruiting another set of very early treated way earlier than the SHRE kids. And we also have neuro parameters, also have cardiovascular parameters on these kids, yeah.
Thank you.
Great, in the front.
Thank you, great talk. I was wondering if you tried to derive macrophages and phenotype them.
No, we haven't, but that's kind of like a hot topic at this stage, and especially with the seeding of the reservoir as they do go and sit in the immune privileged sites. We haven't yet looked at it, but it would be part of our future studies, yeah.
So there's been interest in the recent literature on maternal inflammation driving some of these effects. How early are you capturing some of the children, and is it something you're looking at or thinking about looking at in the future?
Sorry, I didn't get the question.
So some of the maternal parameters might be driving some of these changes that you see in pediatric infection. How early are you capturing the children? Are you able to capture maternal
So I think that would be a key limitation to our study, although the only thing, we haven't collected information related to inflammation in the mothers, and I think that would be key in seeing if that drives inflammation in the children. The only thing that we're looking for in the mother is immune escape variants that may be passed on to children, and that's the only thing that we can relate the mother to. But yeah, there's unfortunately no data on maternal inflammation at this stage.
Great, thank you. Okay.
All right, good morning. Sorry about that again. So I am actually here on behalf of Dr. Tianyan Hu, who couldn't make it today to the conference. And so I'm going to be presenting the work that we did on, like I said, anticoagulation treatments in pigtail macaques. So as you know, cardiovascular disease remains one of the leading non-AIDS causes of death amongst chronically HIV-infected subjects. And this cardiovascular disease is largely driven by a hypercoagulable state, which is accompanied by persistent immune activation and inflammation. So in our previous studies, we demonstrated that in vivo treatment with the tissue factor inhibitor Exelaris alleviates both immune activation and inflammation, as well as decreasing hypercoagulation. We also showed in our in vitro studies that tissue factor and its induced downstream thrombin production tie immune activation and inflammation together with hypercoagulation to the protease-activated receptor, or PAR, signaling pathway. So we hypothesized going into the study that anticoagulant therapies targeting these pathways could help break the vicious cycle of hypercoagulation and immune activation and inflammation, and reduce the risk of cardiovascular comorbidities and HIV infection. So in the study, what we did is experimentally administered a thrombin inhibitor, dabigatran, a PAR1 inhibitor for Apaxar, and to SIV-infected pigtail macaques, and then compared the efficacy of these treatments with our prior treatment with the tissue factor inhibitor Exelaris, which we also administered to pigtail macaques. So for this study, 5 adult male pigtail macaques were used for each of the experimental groups, with administration of the anticoagulants beginning on the day of infection. 8 untreated SIV-infected pigtail macaques were used as controls. Although the treatments were maintained for various periods of time, we assessed all the parameters in the study at the same time points, namely 10, 42, and 80 days post-infection. At each of these time points, which we respectively refer to as acute, set point, and chronic stage of infection, we measured coagulation markers and levels of immune activation and inflammation. So, all 3 anticoagulant therapies resulted in different extents of reduction in hypercoagulation, marked as seen by lower levels of D-dimer, soluble tissue factor, and soluble P-selectin in the plasma compared with the control animals after SIV infection. The treated pigtails also showed lower levels of C-reactive protein and pro-inflammatory cytokines and chemokines. They also exhibited fewer activated CD4 T cells, which was seen as a reduction in HLA-DR and CD38 expression on the CD4 cells. We also observed a lower activation status of the monocytes, marked by a reduction in CD80 expression. So these markers are shown here, but other markers are not. I couldn't include them in interest of time. So if you want to see my posters outside in the hall, I included more of the markers there. But what we found was that all the 3 anticoagulant therapies had beneficial effects in reducing hypercoagulation and immune activation and inflammation. But the Exelaris was clearly the most potent of these treatments. It also was the most consistent and had a significant effect on the parameters all the way through the course of SIV infection. And under normal circumstances, we expect to see what we call rapid progression in the pigtails. But in this case, the animals that were treated with Exelaris had better survival rates than the untreated pigtails, with no progression to AIDS within 100 days post-infection. So another part of the study was correlating biomarkers of hypercoagulation with markers of immune activation and inflammation, to identify any significant correlations between any of these parameters. As shown here in this correlogram, each dot represents a correlation between a pair of markers with only the significant Spearman correlations, data with significant Spearman correlations being shown. The larger and darker dots indicate stronger correlations. So we found that multiple markers of hypercoagulation and platelet activation are significantly correlated with immune activation and inflammation markers. Some of these strongest correlations are listed in the lower left-hand corner. For example, we saw that the coagulation marker PF4 was highly correlated with the pro-inflammatory cytokine IL-17. A strong correlation with IL-17 was also found for soluble ICAM1 and soluble tissue factor, and these two markers were both positively correlated with soluble CD40 ligand. So the conclusions from our study are that there is a strong relationship between hypercoagulation and immune activation during HIV-SIV infection, and it suggests that the use of anticoagulant therapies in the context of these infections may prove beneficial. While all the three of the treatments that we tried here were successful in reducing immune activation and inflammation to different extents, Exelaris was clearly the most superior treatment. And as Exelaris targets tissue factor, it indicates that any potential anticoagulant treatment may be more beneficial targeting upstream factors versus downstream factors like thrombin or PAR1. So I'd like to acknowledge everybody in the Apitre-Pandrea lab who made this work possible. I'd also like to acknowledge our collaborators at the NIH, in particular Drs. Rini Soretti, Ivo Francischetti, and Bruno Andrade for their assistance by providing the TF inhibitor, the Exelaris, for the experiments. And we'd like to thank Dr. Russell Tracy from the University of Vermont for his insight to the study design and helpful discussion, and very much Dr. Rui Ribeiro from the University of Lisbon for his help with the statistical analysis, and of course our funding from the NIH.
Thank you for keeping
and of course the people here at the conference who made this all possible. Thank you.
Thank you. Open for questions at the back.
I might have missed it. Did you look at monocyte activation marker and even metabolic markers? So we know that highly metabolically active monocytes are most inflammatory. So did you look at any of those markers? And second question is, we have seen in experiments using sevelamer in macaques model, for example, that the data doesn't translate directly into humans. So what's your thought on Exelaris?
So yes, we did test CD80 as a macrophage marker here, and we did see the reduction in the activation status. But as far as the metabolic markers, I don't think we did. Like I said, this was partly my study, but it's mostly Dr. Tenyuhi. So if you want to talk to me afterwards, I can get you some contact information for her. As far as the translatability of this study, Exelaris isn't approved yet by the FDA for use in humans, which is one of the reasons we decided to use it here for this study. But I think it has potential. It has a very strong effect here on tissue factor. And like I said, tissue factor is an upstream of the other coagulation factors here. So I think that it has a lot of potential to translate to having a greater impact in humans.
Peter? Okay.
So it's long been hypothesized that there's this bidirectional relationship between coagulation and inflammation, and in the context of HIV, there's a clear increase in both, and you're seeing really striking effects here on blocking coagulation and thrombosis. Are you certainly some of the association between inflammation and coagulation must be driven by inflammation causing coagulation. Others have identified several mechanisms. And so how do you, were you surprised at the degree to which immune activation declined here in this study?
Well, I mean, I think, it is definitely a vicious cycle type situation where you have inflammation driving coagulation and coagulation driving inflammation. So I think that when you're coming in at any point here, you could have a great effect on the total cycle, but it was a little surprising how extensive it was, which really implies that maybe coagulation does have a maybe even bigger impact on setting the whole thing into a cycle than inflammation.
And how does it start, though, right? I mean,
well, it probably starts with the inflammation, but again, once you get into the cycle, it's hard to get out.
One more question at the back.
David Miller, United States. Is there any value for taking a further look on this in regards to interventions for HIV-associated AMI, given that it's becoming much more epidemiologically significant? Acute myocardial infarctions up to about 10% increase over the past 5 years.
Yes, we would like to see this translate more to human research, but we can't really take it there yet because we need the next step in this study would be to look at using these drugs in conjunction with antiretrovirals because we didn't use antiretrovirals for this part of the study. So before we even can talk about using this in HIV patients who are on antiretrovirals, we have to do those tests first.
Okay, well, thank you very much, everyone, and I'd like to thank all the participants for today's session. It has now come to an end.